So I had the privilege of, again, working with Dr. Buchalter recently at a conference on rescue medicines and cluster seizures. So I'm just going to summarize what we talked about. And I think if I could make one statement about rescue meds, I don't have any slides, that's how behind we are, is that there's not a lot of consensus amongst the physicians and the scientists right now. So if you're confused, it's because they are. And the great news is that there is a big interest right now to fix that and to help our patients. There are new rescue meds coming out on the market very soon, different types, and they're moving pretty quickly to make sure this happens. So I'm going to summarize that meeting for you. I'm going to tell you what you can do right now, tell you what we're doing at the foundation, a little bit about how we're working with them to push it forward, and then let you ask questions. So let me just take a quick peek at my time. All right. So first of all, rescue meds are meds that are used to either prevent a seizure that's coming on or abort a seizure that's going on right now. And aborting a seizure or stopping a seizure is used synonymously with rescuing a person who's in it. The biggest problem we have is that there's no agreement on language. So when you go to the scientific literature, the seizures are called a bunch of different things, and there's no clear definition of what they are. So the rescue meds that are out right now are oral lorazepam, or oral benzodiazepines, where they just give them. There are Klonopin wafers. You could give extra dose of pills. That's one rescue. They're having more seizures, so I'm going to give them some more of their benzo, their Ativan, or their Klonopin, or their Picabenzo. There's a ton of them, Versed. And that one's used the most, and you can also give an extra dose of seizure meds. That one's used most of the time. There is nasal midazolam that is not approved in the U.S. for as a rescue med, but it's approved for other things, and it can be used. And that exists in either a nasal spray or in a syringe that has an atomizer attached to it. And then there's the rectal diazepam, I think that most of us know, and that's used the least when you start to look at how often these are used. In our house, the rectal is the most effective because she's pretty much unconscious. She chokes on the nasal, and we can't get lorazepam in her because she's unconscious. So the rectal has always been great for us. The new drugs that are coming out are similar to the old, but there's new nasal interventions that are coming out. There's great evidence that getting it into the nose gets it faster to the brain than taking it orally or even putting it in rectally. It just gets into the brain directly through the epithelium as opposed to having to go through the whole bloodstream. Buccal, so in the cheek, squirting thing or spraying something. There's a film coming out, if any of you guys have seen those Listerine strips. There's a strip coming out that you can stick in the cheek. There's an inhaler coming out, and we've been talking to the person that's making it, and you don't actually have to, like with an asthma inhaler, you have to suck in, I think, just normal breathing, and if you can get enough of it. Almost all of the drugs that are coming out are the same. They're benzos, but they're trying to get them in faster. And then there's also an injector, like an EpiPen, a needle, intramuscular, so it would be a shot in the muscle. And then there's a lot of device work. I'm not going to go into it again like Dr. Buchalter did, but there's a lot on devices. There's nothing definitive. If you've got a kid that'll wear something and has generalized tonic-clonic seizures, they work really great. We've tried a bunch of them with Savannah. Your best recourse is to get online and to ask about these, but it was just a disaster. She wouldn't keep it on. It kept losing signal. It didn't detect seizures when it was supposed to. It detected seizures when it wasn't supposed to, and so it was just ended up being sort of a pain. We got that from you, Elizabeth, a brace, so we're ready to pass it on to the next person. This is actually a great idea if somebody wants to take it and run, but we all pass around devices and share them in Orange County, so if we wanted to do that in LGS, you try the MFit, so you only have to buy one and then you get to try it. Okay, so let's talk about the naming a little bit. Those are the rescue meds that are used, and then it's exciting because there's a lot of interest. There's new things coming because the rectal is the only one that's approved for use in cluster seizures. So what do they call them? They call them cluster seizures, so seizures that are occurring back to back. They call them status epilepticus, so that's like one long seizure. But they're also called acute repetitive seizures, which nobody could agree that they knew what that meant. So acute means short and repetitive means recurring, so no one knows what that meant. Serial seizures, crescendo seizures, obtunded status, these are all words you may have heard. They're trying to condense it all under cluster. and a cluster, with a break between them, or a cluster with no break between them. I don't know how they're going to differentiate between one long one and then back to back to back, because we've seen all those in our kids. The good news is they're working really fast to name it, because these new drugs are coming on the market and the FDA has to approve them for something. So it should be clearer. They'll be approved for clusters, or they'll be approved for a seizure that lasts a certain time. And then the way that they define them in studies is the number of seizures you're having over time, or the length of that seizure. But they also have in writing, like in the approval for the rectal diazepam, is something that says also out of the norm. So it's one of those, you know it when you see it, but I can't actually define it. And so what we take from that is that it's so individualized for each of our kids, which we already know. Like if they had just come in and asked us, they could have probably saved a lot of time and money, right? But they had to discuss it for a long time. I'm kidding. I like to give the doctors a hard time, but they are really trying to help. But it's very individualized. And so what I'm going to tell you at the end of this is what I'm going to tell you now, is that you need a seizure action plan with your doctor. And in that seizure action plan, and these are online, we have them on the LGS Foundation website, epilepsy.com has them. In that, there needs to be a rescue action plan. And it needs to be something that you have discussed with your doctor that is very individualized to your kid. And I can give you guys this talk, I can give you some slides from the meeting I was at of how it's been defined, but it might be different for you. So how's it been defined? So the definition, because there is one approved med, it's gone through the FDA, was between 2 and 3 seizures in a 6 to 24-hour period. So that's pretty much all our kids. I know, right? Right, like how about 2 to 3 seizures in a 1-hour period? Yeah. So they expanded it out to say 3 times the daily average for kids like ours. So if your kid, now this is just a guideline, I would personally not be comfortable with my daughter going 3 times her daily average and waiting to intervene until that point. I would intervene much sooner, and so we need to have that discussion for our doctor. And I do just want to say, just so I'm talking about it, so our daughter Savannah used to go into non-convulsive status every week. And it was escalating a bit. Initially it started and it would just occur rarely, and then it was more often, and then it was monthly, and then it was weekly, and then it was 2 times a week, and then it was 4 times a week. And then, thank God, we found a medicine that helped with that, because I didn't know where it was going. But what she would do is she'd just kind of stare, and her fingers might twitch, and her eyelids would twitch, not blinking, sometimes blinking, and then she'd just kind of, that's what she'd do. And longest she ever did that was about 4 hours. So what we know, what her treatment paradigm was that if she went into status of a convulsive status, so if she went into a tonic-clonic and it went longer than 5 minutes, she'd get the rectal. I personally was never comfortable waiting 5 minutes, so because she always would have maybe a 1 to 2 minute tonic-clonic. So at about 3.5 minutes, I'm getting ready, because that would be really weird for her to go a full 5 minutes. But if your typical seizure is 5 minutes and they're not, and they're not blue, they're not asphyxiating, then maybe intervening isn't what you want to do. So, and then if she had a non-convulsive status, we would intervene after 20 minutes and let it go, because there were times that she might seem to be getting a break where they were back to back as opposed to one long one. So we'd treat after 20 minutes. Now, there's absolutely no evidence to suggest that was the right thing to do. It was just that's what we were comfortable with. And she was getting it, a couple times a week. So that was our regimen, and that still is the case for her, and she gets the rectal. Okay, so I just want to summarize a couple more things, and then we can all ask questions. So why do we want to treat? So, well, first of all, more than 90% of LGS kids will have a cluster or status. We're in the high-risk group, and you're at higher risk of having a cluster or status if you have daily seizures or if you have ever had a cluster or status. So we're at that top of that pyramid, guys. I don't know, I feel like that should be like a tagline or something. Top of the pyramid, club nobody wants to be in. We all know this, but there is actually really good data that the more a person seizes, the more likely they are to cluster. The more a person clusters, the more likely they are to go into convulsive status. And the more likely, and when you go into convulsive status, the longer you let any of these go, the harder it is to get you out. And convulsive status is lethal. So it decreases your blood pressure. It increases the length of the seizure, obviously. Most people will get hospitalized. There's a really high incidence of death, and there is really good evidence that shows that respiration and low blood pressure are worse from a seizure than they are from treating with the rescues, which are the benzos. And the benzos, for those of you that have worked with the benzodiazepines, which are the drugs used for rescue, they can decrease respiration, and you have to monitor the person's breathing, and so there's fear about them. But the seizures are worse, okay? So if in the beginning when Savannah was diagnosed, we were always like, what's worse, the seizures or the meds, you know? We learned after about 5 years it was the seizures. She was like on the same dose of meds, and she went into a huge seizure. She lost a bunch of skills that she had just gained, and nothing had changed med-wise, and she almost died. And so the seizures are if you're wondering and you want to have that chat with me, I'm happy. But they also have really good data that if you intervene at a rescue at the cluster stage, you know, before, and then there's some emerging data that even preventing, so like let's say our kid usually has 10 seizures on average, but they had 20 this morning alone, that maybe preventing, intervening at that point is worth it. So we're getting there. Really does reduce emergency room visits, reduce injury, reduce hospitalizations and all of that. So anyway, so the point is the seizures are worse, respiration issues are a lot worse. I told you when we treat, the only consensus out there is a convulsive seizure longer than 5 minutes. So convulsive status epilepticus longer than 5 minutes, or at the 5-minute mark. But again, what we all need to do is we need to go and have a conversation with our doctors, have our seizure action plan, and within that our rescue medicine action plan. And we need to say, okay, this is what their baseline seizures are right now. And you know, we're still manipulating it, but basically the way I put it is, when do you, as the veteran, the veteranos, start to get uncomfortable? When do you panic? And you don't want to let your kids seize, obviously, but also we all recognize at a certain point when our kids reach a certain age that the seizures are kind of, they're here to stay for a little while. We're going to keep trying, but so at what point do you want to intervene with rescue meds, and what is the risk and the benefit of that? So if you let them continue to seize, I've already told you there are all these consequences. They could have more, they could go into clusters, they could go into status. But if you give them too much medicine, then they will not interact with the world at all. So you have to find that balance with your physician and have that conversation. So I've told you what our rescue plan is. Yours might be very different. I met a mom at this meeting. I was out with Dr. Buchalter, where her daughter goes cyclically, but like every couple of months, into clusters. And the minute they see the clusters, they start loading Ativan. And they'll give 3 or 4 doses of Ativan over like a 4-hour period to stop that from turning into convulsive status. And then they get to go another few months without that happening. And so that's very different. And so it's really hard to define these things. But please, if you don't have a plan, if you don't have a prescription, I think every LGS patient, given that more than 90% of our community has reported at least having one cluster in the past year, you should be walking around with some sort of rescue. So please get rescue meds and talk to your doctor about a seizure action plan. And if they don't know what that is, or a rescue action plan, we will help you at the foundation, either to educate them or to get you to a doctor that can help you get one, and then you can go back to your other doctor to implement it. We will help you. So that is it. The good news, like I said, is that there's a lot of movement in this space right now. So in the next year, I think that we're going to see some agreement on terms. We're going to see some new drugs coming to market, whether we're ready or not, whether we agree on terms or not. And so we're going to have new options, and we're going to see more empowered patients like you starting this conversation with your doctors if they're not having it with you, because you're becoming educated and can go educate them, and then there will be doctors out there that are educated, and hopefully we'll all sort of meet in the middle. But questions? Yes?
How often should you update your seizure action plan? Our plan currently states, so Julian only clusters. That's like every day, only clusters. So our action plan states after 10 minutes, because that's when I started freaking out, right? But we haven't had to give a rescue med in over a year. start feeling uncomfortable at 5 minutes at this point. So should I go back to my doctor and ask to update that?
Yeah. You should bring it up every year,
Every year, okay.
but you should bring it up if the seizures change.
And they have.
And they change all the time in our kids. Now, I mean, I don't know if this is good news or bad news, but they change a lot less when the kids become adults. Their seizures start to take on a more typical pattern. This is what we're seeing in LGS. But as kids, they're changing all the time. So you might need to talk about your seizure action plan and your rescue medicine plan, which should be in the action plan, every month. And especially if you're changing meds, the seizures will tend to change on the meds. So as often as you need to, be in consensus with your doctor about when to intervene. We're just taking questions, Christina.
Oh, I'm just here to look
Oh, okay. Questions? Yeah.
Tracy, our neuro, I don't think has a lot of experience with the top of the pyramid, and so.
You and I have had this chat.
Well, he's already on an active dose of Onfi, so no benzo rescue is really gonna make it dead. I don't think that's true.
That's not true necessarily. I mean, it's not true in my own kid at least, so there is at least a single example where that's not true. So she was on tons of benzos, but we could never explain why a loaded dose of rectal benzodiazepine, right, of diazepam, would break it, but not the regular regimented cycle. And now, mind you, as she grew and these drugs are habituating, she would need more and more, and she was on the max dose at some point. But why did that break the seizure, but not anything else? So no, that's not true. So you might just need to get another doctor involved, maybe go back to the pediatrician and work out an action plan with that doctor. Because you and I are both seen at the same place, and we're having to do some educating of that group there, because they're not really ready for us. Yeah.
Well, and they sort of assume I know more than I do, which is the other question, and that is, she'll say, well, did you use the rescue? Well, no, it was just 3. Like, I don't know personally, I haven't hit that stage. Like, the most we've had in a cluster of tonic-clonics is like 5. So
Got it.
you normalize after a while.
You do.
I don't know whether, so this is a really complicated situation. Do we stop after 2 because it could go on to 3 or 4 or 5? Or do we say, yeah, because you're not going to know?
It's the risk benefit that each of us have to do, and they don't really teach. Like, the doctors are always thinking in terms of risk benefit, but they never say, let me sit down with you and talk. I've never had a physician say, let's talk about the risk benefits. You have to ask yourself, right? So our kids are going to seize, but none of us want to see our kids go into status or keep having more seizures, right? And I don't mean this for the young one, like for the young kids, you still have a chance kind of to stop the seizures. For those of us that have seen our kids seize for 20 plus years, we're a little bit less hopeful, but we never give up. We just, we have a less than 1% chance of responding, but damn it, we're not going to keep trying. We're going to keep trying. So it really is between you and the doctor. And if you could, I don't know if you guys were seen over at the Children's, but maybe we can bring a conversation together with that doctor who is very familiar with the LGS kids and very familiar with rescues, and come to some consensus of when is it time to intervene for you guys, and then what is work. Because a lot of kids do not respond to benzos. They should try, but there are other things that they are going to need. So, Dr. B, you want to add to that? He's always adding to my to-do list.
People, you doctors, vegetable. What about the foundation sponsoring lectures at places? The rescue medicine talk, the seizure action plan talk. Yes, you can get benzos when someone's on Prozac. And rather than, just for efficiency's sake, rather than trying to pick folks off one by one, get onto a grand round schedule and address it to the whole group.
Yeah. I was doing, so the question is, getting doctors to educate doctors through grand rounds. They have grand rounds, pretty regularly, and they're educating, bringing in outside speakers and things. We were doing this. I was, when the genetics, my daughter's story in the genetics, I was going grand round, and I was talking about genetics and educating neurologists about when to test, who to test, how to test, why to test. It's a great idea, but we need physician help like you, because we stopped doing it because hospitals are getting a little freaked out. So what would have to happen is, and we do have this at the foundation, and we had this when I worked at Cure, where we would fund a speaker to go in, but it has to be doctor initiated. So you as Jeff at such and such institution would invite so-and-so, and then the foundation would pay for so-and-so's travel to come in. So if you can help us do that on the MD side, like, spread the word about the program, find the doctors, target the sites, I'm with you. I can't get our current, mine and Sherry's hospital, to even meet with me about how they're not meeting the needs of the really severes, because they think they're great, and I'm glad they think they're great, but they don't. They have to know that they need more education before they're going to receive more education. But there are a lot of hospitals we could work with that maybe are not ours. So, but yeah, great idea. Back there first, yeah.
Just a quick question, because I'm in Canada, so it's a little bit different, and we don't talk about amount of different, like when she falls into a cluster, they time us. So if she's at 3 minutes of clusters, and we don't count how many tonics she'll have in that time, then they have us give us some lorazepam, even if she is on clofazam, okay, and it works great.
Okay.
Yeah.
Yeah.
And then after that, repeat after 2 minutes, so we don't want her to fall into 5 minutes.
Okay.
And
Yeah.
after that, they have us call an ambulance.
Okay. And so, yeah, there is some data. There's not a lot of really great data to guide all the different examples, but there is a lot of data around certain types of seizures in that 5-minute mark. But so like right now, my daughter has a couple seizures a week, mostly at night. If she had 3 tonic-clonic seizures today, even if they were spaced 5 hours apart, I would be really nervous about that. And I don't know that I'd give her a rescue, but I might be calling the doctor, right? Like we try to avoid going to the hospital to ER at this point, but so we need to be having these individual conversations. If the doctors need data, we can put them in touch with brilliant doctors. I mean, Jeff in a way should be giving this talk, or we can give them the data. We have data that we can share with them if they want to help inform them make the plan. But the problem is this conversations, a lot like SUDEP, are not happening. So that's where you can move forward. Let me get Natalie and then Sherry.
So do you think it's also important to have like 2 different types of rescue meds on board, or like multiple plans? Or I mean, I know, so like our daughter, Gstaut years ago was always sort of like it never worked. Now we use midazolam. That seems to work, but it's sort of like if she goes through periods of time where it's at a clustering, then it doesn't work. And then we're constantly having to like sort of tweak that.
To tweak it, yeah.
And then, she went like a year and a half, and it was sort of like, lovely, because we were throwing bottles away constantly, not using them. And then it was like, boom, out of nowhere, she had clustering. And the midazolam worked like, it was like textbook, just like it should have. It was like,
Yeah.
perfect little neat tiny package, but it just really made me think back to, a year and a half ago when we were using like, once a month and, every 2 weeks, and sort of it wasn't working.
Yeah.
On the phone with the doctors.
Yeah, it's really trial and error. So you have to keep reassessing every time the seizures change. Plus, just because a person didn't respond to a med when they were young or had a bad reaction to a med, like Savannah went on Depakote when she was 3, and it made her self-injurious and psychotic, mean, crazy. And then she went on it again when she was like 23, or no, she wasn't 23. I think she was 7. I think she was a teen. And she had no reaction to it. And then she got a rash from Tegretol, but then when she tried it as an adult again, she didn't get the life-threatening rash. And so just because you've tried something doesn't mean it won't work, especially if you've had a big hiatus. So, and I'm not a huge fan of circling back, but when you run out of choices I'm always really honest with everybody here. We're just trialing and erroring. And that was the nice thing about Jeff's learning health system, is because we're trial and error with our kids, but we're not learning from our kids. His learning health system would mean that every time you give Lily midazolam and it doesn't work, but then it does start to work, that would be in their system. It would be tracked for people to research and study and query, and for the next patient to benefit from them. So it's exciting to think about that future. It doesn't help me solve my problems, but I'm okay with that because I understand progress is slow, and the people are working on it, and we can't make everything perfect right away. But Sherry, you had another question, and then Dale. Yeah. When Diastat first came out, there was a lot of fear. This is the first time I'm hearing that that's still being done, because we've moved away from that, where if you use a rescue, you have to call 911. No, if you use a rescue, you need to know CPR. Is the airway clear? Are they breathing? Is their heart beating? And you need to watch that. You need to watch that when you use a rescue. So if we use a rescue on Savannah, we stay with her, we monitor her breathing, we make sure her heart's beating, and we're on watch, and we roll her on her side because we don't want her to inhale her saliva and get pneumonia. So, which she's prone to do. So if your doctor is saying that, you need to revisit it, but you do not need to call 911. In fact, what we're saying now, all of us are saying is, and thanks to the patient movement, speaking of books, if you want to read a book, Jeff's going to kick me for this, go read The Patient Will See You Now by Eric Topol, which is sort of my diary on, no, it's not about you, physicians. We love you, we need you, but the patients need, I suffer the ultimate consequences as the patient. So you should read that book about how patients are really starting to take charge of the system and turn it on its head a bit. The Patient Will See You Now. But so I would get a new plan. No, don't call, but you do need to know first aid. And what we're saying now in patients is that it's actually more traumatic to make us go to the ER and be admitted. We want to be home. So,
Can I just piggyback on that? So,
yeah.
Oh,
No, you're good, Kara.
so you've never called 911 to give your message. The only people who did that was my son's school. But I would they would call 911, call me, I would come to the school and deny transport. So there are ways.
Yeah. The issue in schools, I'm so glad we're out of school now, because issue in schools is actually very political. And it's being used sort of as a pawn among school nurses who are getting cut. And they're saying, we have to administer it. But then we're saying, no, we administer it at home when we're not nurses, And so it's become this political argument, which is very, very frustrating for our kids. But it's the way it is. So, Dale.
I think we probably need to spend more attention on this at the next conference, because the points that you just made, Kara, call 9 times out of 10 when your kid's having a cluster, you can't get a hold of the doctor anyway. They're on vacation, or if you call, you end up with an intern, or you end up with somebody that really doesn't know your kid and or understand the mechanics of what's going on. Just wanted to share with you a lesson that we did once when Adam was clustering. We administered the rescue med, and then we remembered, holy cow, we didn't give him his evening dose of meds. And that exacerbated things unlike anything you could. We ended up in the ER, but as soon as we were able to get his morning meds in him at 7 o'clock and turn on Dora the Explorer, we were all good to go. And
Yeah.
so just an expensive lesson. The other thing though, too, we try to get ahead of things if he's sick, and if we see some strange activity going on, then maybe we'll do something then, just to sort of stop that train from going down the tracks.
Yep.
I say.
There's actually some evidence from clinical trials too, that the patients who are in clinical trials that went on placebo, so you don't make any changes in your medicine and you're not on the trial medicine, actually do worse because you're not changing anything. There's some data, and they're actually at a little bit higher risk of SUDEP. So there's a lot of talk in clinical trials about it's a significant risk. It's not huge, but it is statistically significant about reducing the placebo arm, making trials really short in epilepsy, because we can't be putting these patients at risk. So it's exciting. But I agree with you. If it's weird, you want to get ahead of it. And there's a lot of talk about intervening, not to abort or rescue, but actually to prevent an episode. And I would be bringing that up with your doctor. But the good news is there is a lot of interest in this, but the patients are leading the way. So I am a scientist, and I believe in data and hardcore and the most informed decisions. But I am also a mother of a really sick kid. And when science and tech and medicine can't help us because they're not to that point, I have no problem learning anecdotally from another mother or pushing on the doctors to help us just find a hack. It's a life hack. These are basically life hacks. I want to learn from them. I want to be a part of this LHS as soon as it's up and running. But we have to live with it, right? And so until science catches up, we don't just wait for science to catch up. We should be learning from each other, and we shouldn't just be calling a single mom or a single dad and making that our story. We should be collectively doing surveys, and then we should understand, the different types of seizures. And this is not rigorous science. It helps to form hypotheses, but it is just as important to me for those of us that are living with this hellish, awful disease, right? So, or disorder, or whatever you call it. I don't know. Whatever it is, it's horrible. So, any more questions? Yeah.
Tracy, I just wanted to add one more part to this conversation. It's missing so far. Actually 2 points. Relates to the 911 issue and to making change. The liability. Doctors and schools are terrified of being sued because they are all the time. And so when they're asked to do something, they see liability, there's probably a lawyer on the board that's saying, what's the most conservative thing, call 911. So, we might agree that we don't need to, but just be aware that maybe just saying to whoever, look, I'm not gonna sue you, but it doesn't make sense to call 911. That's a driving factor. The other is to remember that, whereas again, we as a community, and I mean providers, parents, caregivers, can agree to the importance of something, if it's not moved to a legislative the big things aren't going to change. And that is where parent groups and patients are so powerful in medicine. Because when Doc said we'd like to spend more time with somebody, we need more access to this, it's in your self-interest, you're going to make more money. No, when they get, 1,000 phone calls and people aren't going to vote for them, and you're sitting on the door because you have sick children, that has impact. And I think, part of what you can do is push the agenda on levels where change is effective.
Yeah, I agree. So I think about this all the time and have for 20 years, but we as patients, we don't get to silo ourselves. And Jeff is great, and I don't mean to pick on physicians, but they get to go home at the end of the day, right? Scientists get to go home at the end of the day. FDA, NIH gets to go home at the end of the day. Pharma, device makers get to go home at the end of the day. Legislators get to go home at the end of the day. And so they can silo. They can just focus on their thing. We don't. And what the problem is that we now have to interact. We're dependent. It's an ecosystem. So I can go yell at my doctor, but at the end of the day, he's got so many problems and so much pull on him. You have, 15 minutes to get 12 relative value units based on your hospital. No one knows what the hell a relative value unit is, but it's about whether or not he enters information into your EHR. I mean, the doctors are really pulled, but we can work together to change the system. But we as LGS patients and as a foundation need to attack all those fronts, because we are beholden to legislatures and to doctors and to scientists and to industry and to each other and support, all while we're trying to juggle LGS too. And so I spend a ton of time thinking that, and obviously we need to prioritize, but the point is, we're all in this together, so whatever change you can make locally for your child, whatever conversations you can have just with your doctor, are part of a bigger effort that the foundation and so many other advocates around the world are pushing. And Jeff works with the Epilepsy Foundation. We work with them too. So we'll be giving you those opportunities, and if you can do them, great. If you can't, great. And so any more questions about rescues? Yeah.
Did you say that when she's having, what did you call that, when she's breaking
We call it atypical absence, but truth be told, she has 2 kinds of seizures, one called myoclonic astatic and one called atypical absence, and I have no idea which one that is, but she just,
Would you give rescues when she has prolonged
at 20 minutes, yeah. Yeah. Now that was her old plan when she was getting it all the time, because sometimes she would have those and then they would end pretty quickly. If she were to go into I think I'd be giving it at about 10 minutes now, because I'd be panicking because she's just not had them for so long, and so I need to update our seizure action plan. But yeah, if this just goes on, because what we've learned with her is the longer that goes, the harder it is to stop. And it can go forever. It went for 4 days one time because no one believed she was in a seizure. They're just like, oh no, she's sitting up. She's.
And once that episode was over, did you notice a backslide in her progress?
If they went really long, yes. If the longer they would go, the more amount of rescue meds we would need, and the longer it would take her to recover. But the rescues always put her to sleep, and she'd sleep for a long period, and then she'd come back. But yeah, I've seen the seizures take away her speech, and so she's never regressed. But she started having seizures at 2, and she'd gain a few skills, and she'd lose them. But it's like at 2, she knew her colors, she could walk, she could potty train, she could talk a few words. That she never lost, but after that she'd kind of go, lose, and couldn't talk, and then could talk, but then couldn't talk again, and would lose words. So yeah, but she never had some patients, she would lose the colors and lose the walking and lose the talking, and so she never backslid, but a lot of LGS kids do. So yeah.
Quick question, I was talking, I think it was, I don't know the doctor's name, sorry. But I had mentioned with the rescue med, they sort of have to pick my battle, right? But for clusters, clonazepam works really well, and I was sort of wondering if there was any other oddballs in the group, but my little oddball has clonazepam, and he turns into a little psychopath. But that's mixed, and then we found it was a combo with the lamictal, I guess.
Mm.
Is that a therapeutic dose? It works fine, blood-wise, but anytime I have to give him clonazepam or rescue, it's just.
Yeah, we were talking about this yesterday. They wanted to put him on an antipsychotic plus the rescue whenever he clustered because none of the other rescues were working for you. So if anyone has that, or has heard of that, Elizabeth and Nicole, you guys need to connect and talk about that. And then if the foundation can help. The other thing I will say is I don't know how soon the new rescues are going to come out, but there's 4 new rescues coming out, an inhaler, intermuscular, I don't know if you were in here, a film, those Listerine strips? One of those, and nasal. New ones coming out that to try, yeah. And then there's Klonopin wafers now, there's nasal midazolam now, and then there's the rectal benzos now. And then, of course, the stuff at the ER, so. Bleh.
I just wanted to echo what Jill was saying. I think this needs to be the first conversation because the school district is a major issue.
We're done.
They won't even give him the nasal test because the nurse said it's not FDA approved for that.
For that indication,
And
yeah.
so he's 11 and still getting rectal rescue meds, and I know that they're like, sorry, we just
Can't do it. So this is why I am really pushing the ambassador program. So as you guys are ambassadors, it's I have data as a scientist, but I have no skill in communicating with the parents because I'll just burst into tears when they start telling me their stories. But we could start educating. We can do webinars. We can bring in Jeff online for an hour to talk about this and tell you about the data. We can bring in people who have figured out how to navigate the nursing system. We have things we can be doing.
If the doctor prescribed it, why is it up to the nurse to say no?
because it's not FDA approved.
But why is that in her voice? Your doctor's the one that made the decision. She has zero liability there.
She has 100% liability.
She does.
Yes, she does.
Yeah,
And it varies
This is
from school district.
to school
This
district.
is why they won't give it for dialects, even though it's FDA approved. They're like, oh, it's
You brought
marijuana.
it to
We
her, the
can't
doctor
give it to her.
prescribed it, and she's liable.
But there are arguments we could be having. We have to wrap up now, and I do want to take this last question. But there are arguments we could be having. So one of the things, I just want to end with this and then ask this one question, and then we have to switch rooms. But one thing that worked, and I'm not advocating this right now, but it could work. So when you go to your insurance company and they deny something, you can, and your doctor permitted, you can, we've done this twice. We've asked for the medical ID license number of the physician at the company that denied it because they're now taking over primary care of our daughter because they're going against the doctor, and it's worked for us. Now, I'm not saying being a jerk is the way to start, but at the end of the day, we need to start pushing back a little bit as patients and supporting our physicians who know our kids, know the disease, and are saying they need this medicine, and not letting them be political pawns in sort of a nursing movement. I love school nurses, and I actually like unions for the most part. They can be a little crazy, but I want to. It's our kids that are suffering. And we're too tired to have a voice. And so it's time for us, when we can and when we're able, at least for our own kid, to have a unified message. And I think we can do some of that. I think we can find a way. So with that, let's take this one last question and then we're going to switch out.
It's not a question. In
Oh.
Ontario, we have no more school nurses. So the
They're gone.
ones that are administering
Yeah.
the medicine are
Yeah.
the office are doing it, and this is diabetic, this is everybody.
We-
I, as a teacher, have checked blood levels of the diabetic to see and then call the parents because
Yeah.
so you're teaching your staff, but you
Yeah.
don't know the nurse staff.
Yeah, we had a one-on-one aide that gave the diastat at our school, but we had to fight fiercely for it because nothing's easy in LGS. That should be our tagline. All right, we're going to switch out.